Kaposi sarcoma is associated in 100% of cases with a virus called a HHV8, which stands for human herpes virus 8. So why do we develop Kaposi sarcoma and why? It is associated in 100% of cases with HHV8. In this case, we will explain the pathophysiology. So first, we will see an infection caused by HHV8. HHV8 infection occurs through saliva. So it is an infection transmitted horizontally. After we see this HHV8 infection, it penetrates into the cells, endothelial. And in these endothelial cells, what will it do? It will anchor its genome to the DNA of these endothelial cells. And when it anchors its DNA, its genome, in the DNA of the tumor cells, it will trigger the production of certain proteins. These proteins have an important role, which is to inhibit apoptosis, which is programmed cell death on one hand, and on the other hand, they will stimulate proliferation. They will stimulate cell proliferation on one hand. On the other hand, what will it do? It will stimulate certain genes in our genome. So it will stimulate certain genes in our genomes. Among these genes, we have those that code for VEGF and for FGF, FGF3 and 4. So these two, for example, FGF is the endothelial growth factor of vascular cells, and FGF3. It is a fibroblast growth factor. These two will cause the proliferation and multiplication of endothelial cells. So we will see a neovascularization that is tumoral. We will create several vascular formations responding to a vascular tumor. Clinically, what does Kaposi sarcoma present? So before delving into it, in terms of clinical aspects, it is important to know that Kaposi sarcoma itself is subdivided into several clinical entities. First, we have the form known as the classic form. Then we have the form associated with HIV. We have the form known as endemic. And we have another form known as iatrogenic. It is called iatrogenic. So, the form known as classic is seen in subjects of an advanced age. In this case, these are elderly subjects who have a somewhat depressed immune system and begin to develop Kaposi sarcoma. Then we have the form linked to HIV. We have severe immunosuppression with a co-infection with HIV and HV8. A very aggressive form will develop, and it can even be fatal, of Kaposi sarcoma. The endemic form means it is seen in Africa. In certain years, there are epidemics due to HHV8, which primarily affect children. They are considered to have a poor prognosis when they manifest in a form called the lymphadenopathic form, lethal, which means it is fatal. We have the last form, which is iatrogenic. It is due to two things: either the use of immunosuppressants, for example, for a patient who is going to receive a kidney transplant, or, for example, the use of long-term corticosteroid therapy. So, clinically, what are we going to see? We will see three phases. We have a so-called phase, the patch phase, the plaque phase, and the nodular phase. The plaque phase means we will see what looks like reddish and purplish plaques when we apply pressure. With a glass slide, the lesion is negative to diascopy. Why is it negative to diascopy? Because beneath this plaque, or the plaque itself, is made up of malformed blood vessels. They are malformed, which allows red blood cells to leak out. And so we have an extravasation of red blood cells. It's not like a well-formed vessel. When we perform our diascopy, the blood will evacuate from both sides. In this case, in our Kaposi sarcoma, we will not have this evacuation of blood because the blood is already extravasated. On one hand, if we, for example, irritate this area, we will irritate it to look for Darier's sign. So we will rub this lesion. We will see a negative Darier's sign. Darier's sign is found positive in cutaneous mastocytosis lesions. That is to say, we have mast cells in the skin. If we provoke rubbing, we will stimulate the mast cells. The mast cells will release histamine, which will give the lesion a hive-like appearance. Secondly, we will see the plaque phase. What does that mean? A plaque phase? It means that this vascular proliferation has increased its speed and it starts to rise until it gives. an elevation on the skin as if a relief, and it is still red and purple. This is the plaque phase. Subsequently, the proliferation will further accelerate over time. In this case, it will form nodules that can be ulcerated and superinfected. And these nodules, they can be painful. Why painful? Because below we have nerve fibers that can be infiltrated. Because we said it is a locally aggressive tumor on one hand. On the other hand, this tumor, because there is an infection, means it will be surrounded by lymphocytes and plasma cells. And these two, they will release cytokines. And what will these cytokines do? They will irritate the nerve endings and cause pain. How is a Kaposi sarcoma diagnosed? A Kaposi sarcoma is clinically suspected, but the diagnosis of Kaposi sarcoma can only be confirmed by a pathological study. A biopsy will be performed, and during the biopsy, we will find what we explained on a pathophysiological level. That is to say, during the plaque phase, we will see certain blood vessels with poorly formed lumens lined by spindle cells with minimal atypia, and which will allow red blood cells to leak out to the periphery, known as blood extravasation, along with the arrival of lymphocytes and plasma cells. But these elements have not yet reached the papillary dermis, because we have the papillary dermis and the reticular dermis. Since they have not reached the papillary dermis, they will result in a plaque phase, a spot phase. Subsequently, this vascular proliferation will accelerate and reach the papillary dermis, which is located just below our epidermis. In this case, it will result in a skin elevation in the form of plaques or raised areas. Subsequently, this lesion will develop into a nodule. The proliferation is so significant that it has started to form fascicles made by these spindle-shaped and ovoid tumor cells. An ovoid. Thus, these bundles will compress against each other, leaving spaces in the form of slits. These spaces will be occupied by hematites. Not to mention that there can be infiltration at the base of the nerve fibers, there can be ulceration of the epidermis on the surface, and there will be infiltration of the sweat ducts. And the diagnosis will only be confirmed by a pathologist. And the proof that tells us this lesion is associated with HHV8 is when the pathologist conducts an immunohistochemical study of antibodies directed against HHV8, they will find positivity within the nuclei of the tumor cells. And this HHV8 can also be detected through molecular biology using PCR techniques. How do we treat Kaposi sarcoma? There is no curative treatment for Kaposi sarcoma, but we manage the situations. For example, if it is a classic form but the lesion is singular, we can perform an excision of the lesion. But if the lesion, for example, is multiple, we can recommend chemotherapy. If we have, for example, a form that is related to HIV, often these are lesions that are diffuse with several phases. We have lesions that are in the plaque phase, lesions that are in the nodule phase, lesions that are in the patch phase, etc. This means that here we will use antiretrovirals. And we have seen that the use of antiretrovirals in certain cases of these HIV-associated Kaposi sarcomas can lead to a regression. From there, we can have a regression of the lesion. For example, if we have a form that is endemic and it has led to lymphadenopathy, which is lethal, then we will recommend chemotherapy.